Hello, and welcome to this week's Psychiatric Mental Health Nurse Practitioner Board Review. This week we'll be mastering the SSRIs mechanism as well as clinical pearls and adverse effects. Question number 1. What is the primary mechanism of action of SSRIs? A. Increase dopamine in the brain. B. Block serotonin receptors. C. Inhibit serotonin reuptake. Or D. Stimulate norepinephrine release. So, if you will recall what we discussed in last week's PowerPoint, we said we always rule out which one of the answers that we know are wrong. So, and also we look at the last part of the question instead of the first part. So, this is asking what is the primary mechanism of SSRI? So, if you have an SSRI, how does it primarily work? Well, what is an SSRI? It's a selective serotonin reuptake inhibitor, right? So if we look at that, would that mean that it would be A, increase dopamine in the brain, B, block serotonin receptors, C, inhibit serotonin reuptake, or D, stimulate norepinephrine release? So in this question, we know that we can rule out A and D because it's not going to increase dopamine. It's a selective serotonin reuptake. And we know we can eliminate D because it does not stimulate norepinephrine release either. So that's either going to leave B or C. So now we're down to 50-50. So what do we talk about when we say selective serotonin reuptake inhibitors? Let's start with just the basics. SSRIs work by inhibiting the reuptake of serotonin that increases serotonin levels in the synaptic cleft. And so if you rule out the wrong ones, increasing dopamine, that would be more along the lines of bupropion. Blocking serotonin receptors would reduce its action, not enhance it. So there you go. That rules out that one. And norepinephrine activity, that's more in the realms of an SNRI or a selective norepinephrine reuptake inhibitor like venlafaxine. So what is our answer? Let's go on to the next slide. The correct answer is C. C, inhibits serotonin reuptake because it blocks the serotonin transporter, increasing the serotonin in the synaptic cleft. So I hope that helps you to figure out how you can eliminate the wrong answers and usually get it down to 2 right answers. So let's go on to the next question. Why are SSRIs considered a first-line treatment of depression? A, they have a faster onset than other antidepressants. B, they are more effective than all other options. C, they are well tolerated and safer in an overdose. Or D, they cause fewer GI side effects. So let's talk about which one do you think is wrong. I'm going to be quiet for a minute and let you think about that. And I want you to look at this and think about what SSRI is the first line treatment for depression. Okay? So SSRIs are first line because they are safe, they are well tolerated, and they're not lethal in an overdose. So A, they have faster onset than other antidepressants. That's incorrect. Almost all SSRIs take several weeks to work, similar to all the other classes of medications, including SNRIs. They are more effective than all other options. That's also incorrect. Effectiveness is comparable to other classes. When you're talking about other classes, you're talking about an SNRI. So the next one, they are well tolerated and safer in overdose. If you said C, that is the correct answer. SSRIs do have a favorable safety and side effect profile, and they cause fewer GI side effects, which is D. That is incorrect because GI side effects are actually quite common with SSRIs. And as for a board question, They love to test safety questions. And so remember tolerability. They're going to be asking why something is first line with a disorder. Let's go on to the next question. Which SSRI is considered the most activating? A, paroxetine, B, fluoxetine, C, sertraline, or D, escitalopram? Now, if you'll notice on this question, what did I not do? I did not put both names of the medication, and I did this intentionally because after doing some research last week, I, I I am under the impression the board may have changed a little bit, and they do not always include both names of medication. I do not know that for certainty. Either way, you should be able to know the name of both generic and brand name of these medications. So, with that aside, what SSR is considered most activated? Now, we actually did talk about this in the last presentation. A, paroxetine, B, fluoxetine, C, sertraline, D, escitalopram. So I'm going to give you a moment to think about that and rule that out. And we'll go on to the next slide. So if you said fluoxetine, you are correct. So let's talk about that. Fluoxetine is your activating SSRI. It wakes people up. Paroxetine is the opposite. It's sedating. While sertraline, Zoloft is neutral, and escitalopram is very well tolerated and gentle, so it is not activating. So, something to remember about this question is when you're treating depression with fatigue versus anxiety with insomnia, that'll help you pick the right agent, right? Because if somebody comes to you and they're depressed and they're fatigued, you're going to want to give them an activating agent versus somebody that's anxious. You're not wanting to give them an activating agent because that can make their anxiety worse. So, that'll help you to also remember that. So, next question. What adverse effect is especially associated with fluoxetine, sertraline, and paroxetine? A, sexual dysfunction, B, weight loss, C, skin rash, D, tachycardia. So, I'm going to give you a moment to think about this. So, we're talking about three drugs in this question: fluoxetine, sertraline, and paroxetine. And we want to know what adverse effect is associated with all three of these meds. So if I was looking at this question and I wasn't sure, I think one of the first things I would ask myself is what class do all these drugs fall in? Are they all an SSRI? Are they all an SNRI? Do they classify as other? So that would be one of the first things I think I would do. And then I would look and I would be, well, tachycardia. Maybe I'm not sure about do all three of these cause tachycardia. What about skin rash? I wouldn't expect to see a skin rash with all three of these. That would be one of the ones I would immediately rule out. We are going to be talking about a drug that skin rash is especially appropriate to. And if somebody you might say they have an allergic reaction, well, they're going to have a skin rash. But with three medications, I don't think so. Weight loss. Weight loss is an interesting one. Some of these drugs can cause weight loss, while some of them can cause weight gain. Your answer is going on to the next slide here. If you chose sexual dysfunction, that's correct. These SSRIs have a high rate of sexual side effects. Weight loss is incorrect because some do cause weight gain, like we said. And fluoxetine, it does initially cause some weight loss. And a skin rash, like we said, that's rare with SSRI. Tachycardia, we don't even typically see that associated with an SSRI. So I will also go on to say a board question and something the board likes to test on. Sexual dysfunction, it's one of the top reasons people stop SSRIs. And while these three drugs are the most commonly implicated with sexual dysfunction, weight changes, tachycardia, rashes, they are far less common and prevalent. Know that sexual side effects are common and impactful. That's what the board really wants you to know. They want you to know that, and they want you to be aware and ask your patients, both male and female, are you having any sexual side effects from taking these medications? Because the patient may not be one to bring that up with you, but if you bring that up with a patient, they are likely to say, yes, it's causing me problems with um, either having an erection or an orgasm. Or I usually hear that more males will usually talk about that more than females, and a lot of females will say, yes, but I'd rather feel better than I care about sex right now. But either way, at some point they're going to begin to feel better, and sexual dysfunction, if the medication is getting in the way of a good sex life, then they're going to stop taking it. So the answer to that is A. Next question. What is a common gastrointestinal side effect of an SSRI? A. Constipation. B. Gastric ulcer. C. Nausea. D. Reflux. So we're talking about SSRIs here if we're looking at that. And we want to know what a common GI side effect is. So I'm going to give you a moment to look at this question. And I want you to start thinking about a common GI side effect. Rule out the one that you know is not going to be right. All right, constipation. That's incorrect. That's most common seen with SNRIs or TCAs. Gastric ulcers. That's incorrect. That's not a known SSRI side effect. That would have been one of the answers I would immediately have ruled out and said that's just not going to be the answer. C, nausea. I would have said nausea. Obviously, C is the correct answer. Nausea is common, especially in the beginning of treatment. That's why we start low and we go slow. And that's a way to remember that. We don't want to have our clients experiencing nausea. Again, that will stop them from taking the medication. And then reflux. Reflux is not a direct SSRI side effect. Teach patients to take SSRIs with food and expect some nausea for 1 to 2 weeks, minor nausea. If you start low and you go slow, they should not have severe nausea, and they definitely shouldn't be vomiting on a low dose of an SSRI. Next question. What is the recommendation when starting SSRIs in patients with anxiety? So if we go to the end of this question, we want to know about SSRIs in patients with anxiety, right? So, what are we recommending if we are starting an SSRI in patients with anxiety? A, start with a high dose for fast effect. B, start with a lower dose and titrate slowly. C, avoid SSRI entirely. D, combined immediately with a benzodiazepine. Now, which one of these answers are you going to be able to rule out immediately? And then, which one do you think is correct? Let's go on to the next slide. So if you said B, start with a lower dose and titrate slowly, you are correct. And actually, we already talked about this in just a few slides back. Low doses reduce the risk of initial anxiety spikes. So you start low and you go slow. Start with a high dose for fast effect. That's incorrect because that's only going to cause agitation. It's going to cause way more side effects if you start with a high dose. And it's going to cause your patient to become non-compliant and not want to come back because they don't want to be on medication that's giving them a side effect. Avoid SSRIs entirely. That is incorrect. SSRIs are the first line for anxiety. And we don't want to avoid them entirely. So again, that's one of those that we just know that's wrong. And D, combined immediately with benzodiazepine. That is something we don't want to do. Benzos are used only for short term. They are not recommended for long term, and definitely not recommended as an immediate combination. So our correct answer of this is B. Start with a low dose. Start low, go slow. I always warn patients that SSRIs may temporarily increase anxiety. That is actually a real world pearl that can help you remember and get a board question correct. Always warn patients that SSRIs may increase their anxiety initially, but we will start low and go slow. Next, what is the recommendation when starting SSRIs in patients with anxiety? A. Start with a high dose for fast effect. B. Start with a lower dose and titrate slowly. C. Avoid SSRIs entirely. Which patient population is at increased risk for suicidal ideation when taking SSRIs? A. Pregnant women. B. Elderly. C. Children, adolescent, and young adults. D. Patients with chronic pain. We also talked about this in our last review. So if you think about this, what are you immediately going to rule out? We're talking about what population is at risk for suicidal ideation when they're taking an SSRI. Give you a moment to think about that. And if you think about it, there's actually an FDA black box warning on SSRIs, particularly for this patient population. So let's go ahead and go on to the correct answer. So A, start with a high dose for fast effect. We know that's incorrect. A, pregnant women. That's incorrect. Pregnant women, they can take SSRIs. They just require careful monitoring, but they are not the highest risk. Elderly, again, incorrect. They are actually at a lower risk than younger individuals. If you said C, children, adolescents, and young adults, you are correct. This group has an FDA black box warning for suicidal ideation. And if you said patients with chronic pain, that's not even a specific risk group. And so that is incorrect. And that should have been one of the ones that you immediately rule out, would have been D in this case. We'll talk more about pregnancy and what medications are safe and not safe. We'll also talk more about uh, children, adolescents, and young adults and what medications are safe for them. But SSRIs do come with a black box warning saying that, to watch for increased depression and suicidal thoughts when they're starting an SSRI. Always monitor any patient closely, but especially those under the age of 25 when initiating an antidepressant. Our next question: which SSRI is most associated with insomnia due to its stimulating properties? A. Fluoxetine. B. Paroxetine. C. Citalopram. D. Vilazodone. So we already answered this in a previous slide if you think about it. So I'm going to give you a moment to look over the answers, but we want to know which SSRI is linked to insomnia. So let's go on to the next slide. So why are SSRIs considered the first line for treatment for depression? If you chose C, they're well tolerated and safer in overdose, that is correct. SSRIs do have a favorable safety and side effect profile. If you said A, they have a faster onset, that's incorrect. SSRIs take several weeks. If you said they're more effective than other options, that's incorrect. Effectiveness is comparable to all other classes, and GI side effects is an actual common with all SSRIs. Which SSRI is considered the most activating? So, which SSRI is most associated with insomnia? If you said fluoxetine because of its stimulating property, you are correct. It's actually recommended that you take it in the morning in order to, so it will not keep somebody awake because it does cause some stimulation during the day. Paroxetine is more sedating. Citalopram is usually neutral in energy level, and vilazodone is incorrect. It does have some mild insomnia that could occur, but it's not the most active. Next question. What syndrome can result from the abrupt SSRI discontinuation? A. Neuroleptic malignant syndrome. B. Serotonin discontinuation syndrome. C. Serotonin syndrome. Or D. Hypertensive crisis. So I'm going to give you a few moments to look these over, and I want you to think about which is the incorrect answer. And then I want you to think about what you think is the right answer. So what syndrome can result from abrupt SSRI discontinuation? If you said B, serotonin discontinuation syndrome, you are correct. Abrupt discontinuation, that is called serotonin discontinuation syndrome. And that is something that where someone experiences flu-like symptoms with brain zaps. It's not serotonin syndrome where you have too much serotonin. And it's not a hypertensive crisis like you would see with an MAOI. And it's not neuroleptic malignant syndrome like you would see with an antipsychotic. So it's real important when you're talking about SSRI and discontinuation to remember to teach your patients to not stop SSRIs cold turkey. Always taper them slowly. Fluoxetine, B, vilazodone, C, fluoxetine, D, sertraline. If you said A, Boroxetine, you are correct. If you recall a few slides back, I think it was the last presentation where we actually talked about Trintellix used to be known as Brintellix, and the FDA required that name to be changed. I don't think I said it required the name to be changed, but that is what happened, as I recall. Is that the name had to be changed? It sounded similar to another drug, if I recall. Maybe that'll help you remember that. But vilazodone is incorrect. That's Vibrant. Fluoxetine is Prozac, and sertraline is Zoloft. This is why it's important for me to only put one name of these medications instead of both names on some of these slides in case you do get questions like this, because it's easy to get confused when you're beginning psychiatric mental health nurse practitioner and you're in practice all by yourself. It's easy to Google the name of these medications and learn both names. And a lot of times also, your prescribing software will have them in there. But for boards, you've just got to learn them, memorize them, know them. And in professional circles, you only use the name vortioxetine. You do not say Trintellix. That's not how we usually talk about it. You talk about fluoxetine, not Prozac. You talk about sertraline, not Zoloft. Which newer SSRI may offer potential cognitive benefits according to the manufacturer claims? A, vortioxetine, B, vilazodone, C, escitalopram, B, paroxetine. So it's talking about which newer SSRI may offer potential cognitive benefits according to manufacturer claims. So we're wanting to know cognitive benefits, and we're wanting to know a newer SSRI. So if you're familiar with SSRIs and you can recognize any of these that are older, that's going to help you answer this question. And so if you said A, vortioxetine, you are correct. Although there is no strong evidence, it is marketed this way. And you'll see this with a lot of these drugs. So, that's just the answer to the question, but that is how it is marketed. Vilazodone is primarily marketed for anxiety and depression. Escitalopram is not associated with any cognitive claims, and paroxetine is incorrect. It may impair cognition in some older adults. What type of enzyme inhibitors require dose adjustments when using vortioxetine? Now, if you recall, one of the things I said is that we're going to have to learn these ACE inhibitors. And so our next slide is going to our next presentation is going to be on ACE inhibitors, because it's something that you're just going to have to memorize. And because I'm already getting some questions about this, and you're probably already having to know this, it's important in school for exams. We're just going to start reviewing that. And that way, when we come across these kind of questions, you're going to be like, oh, yes, I remember that. We recovered it, and we talked about this in board exam. So our answer is A, MAO inhibitors. B, CYP1A2 inhibitors. C, CYP2D6 inhibitor. Or D is a COMT inhibitor. So it wants to know which type of enzyme inhibitor requires a dose adjustment when you're using vortioxetine. So vortioxetine is a CYP2 2D6, and it is the main enzyme that metabolizes viroxetine. So your correct answer is C. MAOIs are a no-go altogether. You should know that because we talked about that. They're contraindicated. They're not adjusted. CYP3/4A is more relevant to vilazodone, and COMT is unrelated. And again, a board Pearl, always be alert to your CYP interactions because they're easy to test and you will see a lot of questions on them. And when we do that review the next time, I'll try to give you some clinical pearls on how to remember them, and because they are board questions, and one question can make and break a board exam, whether you pass or fail. And I'm not trying to give you anxiety. I'm just trying to give you the reality of board exams. Okay, next question. Which side effect is most common to both viroxetine and vilazodone? A, increased appetite, B, nausea, C, hypertension, D, hyperkalemia. So give you a moment to look at that. And we're talking about both viroxetine and vilazodone. And it wants to know which side effect is most common. And if you really think about this, hyperkalemia, what's that? Too much potassium, right? What about hypertension? Do they cause hypertension? Do they cause nausea? Do they cause increased appetite? So if I was looking at this and I wasn't sure, I think I would think A or B. Let's go on to the next slide. And the correct answer is B, nausea. Nausea is correct because both of these medications do cause GI upset. I will tell you the vilazodone and viroxetine, the main reason people usually stop these medications is because of nausea. Increased appetite is incorrect. Neither is associated with that. Hypertension is very rare with an SSRI. And hyperkalemia, that is not an SSRI related issue. So I hope that's a helpful way to help for you to remember it when I tell you that the main reason people stop vilazodone or viroxetine is nausea. Well, what serotonin receptor activity is shared by vilazodone and buspirone? A 5-HT2A antagonist, that's A. B is a 5-HT3 antagonist. C is a 5-HT1A partial agonist. And D is a 5-HT1D agonist. And again, here we go again with these the hard questions, right? These the 5-H2 receptors, like the CYP receptors. And again, I hate to tell you this, but it's just something that you're going to have to know. And if you don't know, just guess right now. What do you think? Let's go on to the next slide. So, I mean, I'll be honest, this is a hard question. A shared receptor activity both vilazodone and buspirone have is a 5-H2 1A. They're both a partial agonist, which makes C correct. This is linked to anxiety effects in both drugs. 5-H2A or the 5-HT3 rather is not the shared link here, and 5-HT1D is for migraines. And again, the boards may throw in receptor subtypes to see if you really know mechanism differences. And that's why in the next, we'll probably do a couple of more of these reviews because they are difficult to remember and they are common board questions. I remember hating these questions on my boards, and to this day, I will still look up if I'm doing mouth swabs where it determines what a psychotropic medication is. It works well for a patient. It actually has the chromosomes listed, and I will sometimes have to go back and review the chromosomes associated with the medication because you may be having an off day, or there's so many you just can't memorize them all when you're looking at them all, and you need a refresher. And when you've got a drug book in front of you or the internet at your fingertips, it's easy. But at boards, you've got to have these memorized. So we'll do a few more of these so you'll begin to learn them. Next question. Which class of medication should be monitored when combining with SSRI due to interaction risk? Which class of medication should be monitored when combining with an SSRI due to interaction risk? An a CYP enzyme inducer inhibitor. There we go again, right? A B, calcium channel blocker. C, protein pump inhibitor. D, NSAID. I'm going to give you a few moments to look at that. And I want you to think about what do you think about that? And actually, if you think about what we've been talking about, I think you can guess the right answer on this question. Even if you're saying right now, I have no idea, Robin. I think you could look at this, and you would be able to pick the right answer. Let's go to the next slide. If you said A, CYP enzyme inducer inhibitor, you are correct. And why did I say that? You could probably pick it because we're talking about enzyme inhibitors, the CYP, right? And none of the other answers have that. Calcium channel blockers, they have no major interactions with SSRIs. Protein pump inhibitors, they're not even relevant here. And NSAIDs, that's partially correct. They are a risk of GI bleed, but they're not the main concern. What's our main concern? The thing that we're talking over and over again, the CYP enzyme inducer inhibitor, because they can raise or lower SSRI blood levels. So be cautious when you're treating comorbidity, anxiety, and depression. You want to know which inhibitors do what. Let's go on to the next question. What symptom can worsen SS if an, what symptom can worsen if SSRIs are titrated too quickly in anxious patients? A, mania. B, anxiety or agitation. C, weight gain. D, bradycardia. So, which symptom can worsen as if an SSRI is titrated too quickly in anxious patients? So, we have an anxious patient. What symptom can worsen if we begin to titrate it too quickly? If you chose anxiety or agitation, you are correct because rapid titration will worsen anxiety temporarily. So, if you increase the dose too quickly, agitation and anxiety can spike. It's not mania unless the patient has bipolar disorder, and weight gain and bradycardia are totally unrelated. So be cautious when you're treating comorbidities like anxiety and depression. But mania, not correct. Weight gain, incorrect. Bradycardia, not typically effective to the heart rate. So our correct answer is B, anxiety or agitation. Why are SSRIs considered safer in an overdose compared to a TCA? We talked about this in a previous presentation. A, they act faster. B, they have fewer cardiac toxicities. C, they cause sedation. D, they increase norepinephrine only. So which SSRI is considered safer an overdose compared to a TCA rather, I'm sorry. Going on to the next slide. If you said A, that's not correct. Their onset is similar. If you said B, they have fewer cardiac toxicities, you are correct. Because remember, overdose safety, SSRIs are safer in overdoses because they don't cause cardiac conduction issues like a TCA does. The speed of onset is similar to other antidepressants. Sedation doesn't protect in overdoses. Always consider safety in suicidal patients. So there are fewer cardiac toxicities. Do they cause sedation? That's incorrect. Sedation does not affect overdose risk. And D, they increase norepinephrine only. SSRIs, you should have ruled that out immediately because they are serotonin selective reuptake inhibitors. But again, for board pearls, always consider safety in suicidal patient. Vilazodone is primarily metabolized by which enzyme? Words, difficult. When you begin doing these CYP and these 2D6s, they all begin to run together. So vilazodone is primarily metabolized by which enzyme? A, CYP2D6, B, CYP1A2, C, CYP3A4 rather, or D, CYP2C9. I'm going to give you a few moments to look at this. I know it's a hard question, but I want you to think about it. Think about what you've learned in your classes, and think about what these enzymes, which ones we've already talked about, and think about vilazodone. Okay, if you said CYP2D6A, that's incorrect. You see that more relevant to fluoxetine and paroxetine. If you said CYP1A2, that's incorrect because they're not the main enzyme involved. If you said CYP3A4, that's correct because vilazodone is metabolized by the CYP3A4 inhibitor. And if you said CYP2C9, that's incorrect because it's not involved at all. So vilazodone metabolism, CYP34A is the key enzyme for vilazodone. 2D6, it's more for fluoxetine or paroxetine. The 1A2 and the 2CD, they're not the main players here. Strong inhibitors like ketoconazole, which is actually used for like a yeast infection, or carbamazepine. That's also not correct because that's typically used for a seizure disorder. And so the answer to that is C. That's a tough question. What common symptom might prompt a provider to switch SSRIs or reduce the dose? A, sexual dysfunction. B, increased hunger. C, night sweats. D, hypertension. So what common symptom might prompt a provider to switch SSRIs or reduce the dose? So if we talk about this, what do you think is not the right answer here? What let me ask the question this way. What does an SSRI, which of these symptoms does an SSRI not even have to do with? If I'm teaching a patient about an SSRI, what am I not going to be talking about? Am I going to be talking about sexual dysfunction? Absolutely. We already talked about that, and we'll be hearing about it a lot more. We talked about increased hunger. Did we talk about night sweats? I don't think so. Night sweats are common with some of these meds, sertraline in particular. I have some patients, but it's not usually bothersome enough to for them to want to stop it if their depression's getting better. And hypertension, we've already said, is not usually associated. So with that, let's go on to the next slide. If you said sexual dysfunction, you are correct because it is the most common cause of discontinuation or switching. Increased hunger, less frequent and not usually dose limiting. As a matter of fact, a lot of these medications, um, you know, that's less frequent and not usually dose limiting. Really has nothing to do with switching a medication. Now, if there have been significant weight gain, I would argue that could be an answer, and they would want to go off of it if they were having changes in their cholesterol, things like that. Night sweats, rare, not a primary concern. Hypertension, SSRIs don't usually raise your blood pressure. So again, sexual dysfunction, it's the number one reason for patients to stop taking them. We want them to get better. We want them to stay on them. We want them to talk to us about it. So if they're having it, we want to take them off of it, find another drug where it's not a problem. Which is a common adverse effect of vilazodone or Vibrad? A, weight gain, B, sedation, C, diarrhea, D, tremor. So we're talking about Vibrad or vilazodone, and we want to know which is the most common adverse effect. So if you think about it, we've talked a little bit about this and as a side effect overall. Not this one specific, but a group of side effects that one of these one of these symptoms target. To say it better, let's just go on to the answers. So if you said weight gain, you're incorrect. Vilazodone is weight neutral for most patients. If you said sedation, that's incorrect. It's more activating than sedating. If you said diarrhea, that's correct. And that's where I was going with when I said nausea, vomiting, we go slow. We start low, go slow because we don't want to have those kind of side effects. Diarrhea, nausea, that's a GI effect. And that is why that is a common adverse effect. And if you said tremor, we're going to talk about tremors later on, but that's going to be with other medications. It's not usually going to be with SSRIs. So that could be an automatic rule out. Which SSRI is least likely to cause sedation? A, fluoxetine, B, paroxetine, C, fluoxamine, or D, escitalopram. So they want to know which is least likely. And pay attention to those words, least and most, because I can't tell you how often I have missed test questions because I've not slowed down and read the question. And it wants to know which is least likely to cause sedation. And we've already talked a lot about fluoxetine, right? We've talked a lot about it. So we look at this, go on to the next slide. That's the correct answer. Because fluoxetine is activating, it's not sedating. Remember, we take it in the morning because we don't want to keep them awake. Paroxetine is not known to cause sedation and weight gain. Fluoxamine, it's incorrect because it can be sedating. It's incorrect because it can be sedating. And escitalopram, it's incorrect because it's neutral to mildly sedating in some. So if you're going to take it down to two, it'd probably be A or D in this case. But the answer is A, and we've been over that enough now to where you probably should have known that one at this point. What should be done if a patient misses multiple doses of an SSRI? A, double the next dose. B, stop taking it and restart it in a few weeks. C, resume the regular dose and monitor for discontinuation symptoms. D, taper immediately. So if you have a patient that misses multiple doses of an SSRI, what do you have them do? Do you tell them to double up? Do you tell them to stop taking it and restart it in a few weeks? Do you start tapering it immediately? Well, if they've already missed multiple doses, they've already begun to taper it. So I would say that's wrong, right? I'd automatically rule D out, right? Let's go on to the right answer slide. So doubling the dose, you never want a patient to double a dose ever. That's dangerous. It can cause an overdose and side effects. And remember, boards is all about safety. You never want them to double up on the dose. B, stop taking it and restart in a few weeks. That answer doesn't even make sense. It's not clinically recommended. Why would you want somebody why is not therapeutic communication, by the way, which we'll be covering because that's a lot of board questions, but you would not want somebody to stop taking a medication that if they come to you and are depressed, let's say, well, let's stop your SSRI, come back to me in 2 or 3 weeks, and we'll restart one because you missed a night or two. That doesn't make sense. C, resume the regular dose and monitor for discontinuation syndrome. That's correct. You want to resume regular dosing and educate the patient. Taper immediately, and we already talked about that. Tapering is it's a planned it's not something that is for planned discontinuation. That doesn't even make sense. So let's talk about that. If a patient tells you they missed, they give you a call and they're like, "Hey, Robin, I missed my dose yesterday, and what do I do?" And they take it at 9 p.m. and they're calling me at 9 a.m. That so they missed one whole day. I would just tell them to resume it that night at 9 p.m. I wouldn't tell them to take it at 9 a.m. that morning. That's only, I that would be, I would want them back on the same schedule they had. So if they've missed one day, just don't just if they take it at 9 p.m. on a Tuesday night, they miss Wednesday. The goal would be have them resume Thursday 9 p.m. If they were taking it at 9 a.m. on Tuesday and they miss Wednesday, I'd have them take it at 9 a.m. on Thursday. Same thing, even if they miss 2 doses, I would have them retake it. If they start missing, we're going to talk about a medication that you have to be really careful. And if they miss 4 more doses, you have to restart altogether. And we'll talk about that at a later slide presentation. So this is an important thing. Uh, and discontinuation syndrome, that you're going to see on the board. We'll talk more about that, but it's flu-like symptoms and brain zaps. And if a patient's missed a dose, always ask them, do you have flu-like symptoms? Are you having brain zaps? And also if they stop taking a dose of medicine before and they say they had a hard time coming off of it, you want to know that. Brain zaps, for those of you that don't know, they're electrical shock-like sensations that originate in the brain and they radiate to the other parts of the body. They're uncomfortable. They are really short-lived and they're commonly associated with antidepressant discontinuation syndrome, which usually does occur when a person stops or reduces the doses of medication like an SSRI suddenly. It's often described as like a head hiccup, a buzzing sound. It only lasts for a second or two. There are sometimes when you can get brain zaps that are significant enough to stop a medication, but we're not talking about that right now. So, next question. What is the main reason patients may be prescribed several different SSRIs before switching to another class? SSRIs must be rotated. That's A. B. Individual response and tolerability vary. C. Insurance mandates it. D. SSRIs work better when cycled. So, which of these answers is incorrect? If you said insurance mandates it, you might think that's correct, but insurance does not really mandate much of what we do. It shouldn't. They try, but it shouldn't. So, what's the main reason patients may be prescribed several different SSRIs before switching to another class? Response and tolerability, they vary person to person, and you may try 2 to 3 SSRIs before switching classes. There's no need to rotate SSRIs by rule. Insurance doesn't dictate this. Cycling isn't even a thing in SSRI uh, therapy, so that is not even correct. I would immediately have ruled out C and D. So that would have said to me, we're not even on the answer slide here. Let's go there. So A, incorrect. SSRIs must be rotated. They're not. Individual response and tolerability vary. That's your correct one. One SSRI may work better for one patient than another. Insurance mandates it. That's not typically the case. And D, SSRIs work better when cycled. Cycling is not supported in clinical guidelines. Now, enough said. Next slide. What is serotonin syndrome? A condition caused by low serotonin. B, a potentially life-threatening reaction from too much serotonin. C, a long-term side effect of SSRIs. D, a withdrawal symptom. So what is serotonin syndrome? It's asking you just for a plain out definition. Is it caused by low serotonin? Is it life-threatening from too much serotonin? Is it a long-term side effect of SSRI? Or is it a withdrawal symptom rather? So serotonin syndrome is too much serotonin. So if we go onto the answer screen, A condition caused by low serotonin. That's incorrect. If you said B, a potentially life-threatening reaction from too much serotonin, that's the correct answer. Too much serotonin is serotonin syndrome. You want to look for agitation, increase in your reflexes, confusion. It's not about discontinuation. That's something else. That's totally different. And it's not a long-term side effect. And it's not bradycardia or low serotonin. You need to know the difference, though, between serotonin and discontinuation because those are high yield topics on the boards. You will have to know the difference between serotonin syndrome and discontinuation. And we're almost done here. Which SSRI has been associated with an increased risk of osteoporosis? A. Citalopram. B. Viloxamine. B. Paroxetine. D. Escitalopram. I'm going to give you a few moments to look at these. You have A. Citalopram. B. Viloxamine. C. Paroxetine. And D. Escitalopram. I'm going to let you look at those for a moment and think about it. What have we talked about? And which of these methods we talked about? All right, let's go on to the answer. So I think this may be the last one. So if you said if you said paroxetine, you're correct because it has an anticholinergic property that may affect bones. So paroxetine is linked to osteoporosis in older adults. Citalopram, on the other hand, and escitalopram, they're safer in this group. That's why you see primary care providers. You will have primary care providers come to you, and that's the main drugs they put these patients on because to them, they think they're the safest. And for a lot of reasons we won't go into, they're the hardest to get off of. But in a primary care's eyes, they view them as they have the less drug-to-drug interactions. They are safer in older people, so why not? But then when they come to us, we have to wean them off. So paroxetine is linked to osteoporosis in older adults. Citalopram and escitalopram are safer in the group, and fluoxamine isn't commonly used in older adults. Be cautious with paroxetine in geriatrics. It's sedating and anticholinergic, and it does affect bone density. All right, that is the end. So I just want to say, if you're finding this helpful, please like, subscribe, and give it a thumbs up. As of I have a look today, but I don't have any subscribers. If you all, the more you subscribe, it's free to subscribe. This takes a lot of time to record these slides, and I remember when I was going through my PsychMP program, every morning getting ready for a class in clinical, I would put a YouTube video on and listen as I was doing my hair and putting on my makeup. And I would listen until I would remember. And I can't tell you, not did it only help me pass boards the first time, it helped me to pass exams because a lot of this stuff is on your exams. Your instructors are going to get these questions. A lot of these questions I'm getting from exam review books. And I'll be linking some stuff down below where you can get some practice exam questions. So give it a thumbs up because it gives it an algorithm. Like, subscribe, hit the notification bell. It'll tell you when I put up a new presentation, which will be in a few days, and we'll try to do the inhibitors because I think that's going to be one of the hardest ones and one of the ones that you're going to need to be reviewing and listening to more and more. And I'm a big person on mnemonics. Like if you remember Siggy Caps early on, when you were Siggy Caps, for if you recall, is what I write down when I'm assessing a patient. Are they sleeping okay? Like, so for the S, interest, guilt, so that's sig, right? E is energy. So sig, guilt, I have to think. C, E, CALPS, concentration. A is appetite. And then the S is suicidal ideation. And every time I do an assessment, I write that down as SIGI CALPS so I can make sure that by the end of my assessment, I have hit every one of those questions for my first intake appointment, because those are the symptoms you want to know for every patient. So I think, and there's a mnemonic for anxiety we'll talk about later on. So I'm going to try to teach you as many mnemonics as I can, and hopefully they'll stick with you. It's like algebra, what was it, my dear Aunt Mary, to learn the order of, addition, multiplication, and a division. And that's what got me through algebra. Um, so I'm going to hopefully do the same for you. And please remember, I do offer one-to-one tutoring. I'm happy to do that if you're willing. Send me an email, and I will talk to you about the cost of that. I try to make it very cost effective for you, because I want you to pass boards. We need more psychiatric mental health nurse practitioners. We need more mental health providers overall, and I want to help you to pass boards. So I try to make it cost effective. So I do offer you hourly one-on-one tutoring. And if you feel better in a class of 3 or 5 people tutoring, so you won't be put on the spot, happy to do that. Get together a class of 3 to 5 of you, and we'll do it like that. And if you agree to take 10 review sessions with me and you don't pass your boards on the first try, you get your money back. So I do individual, and then also if you're interested if you're close to graduating, getting ready to pass your boards, me and my office manager, we offer how to start your own practice, how to get that go up and going. So that's another thing that we offer, and we do that for a very low cost, because we want to make that effective for you as well. All right, this has been an hour long enough. Thank you for watching. I'll see you next week. Have a wonderful week. Bye bye.